പ്രാർത്ഥനയ്ക്കായി നമുക്ക് എഴുന്നേറ്റ് നിൽക്കാം. പിതാവിനും പുത്രനും പരിശുദ്ധായ്ക്കും സ്തുതി, ആദ്യമോ നന്ദിയേക്കും തന്നെ. ആമേൻ. പരിശുദ്ധനായ ദൈവമേ, സ്വർഗ്ഗസ്ഥ പിതാവേ, ഈ ജൂലൈ മാസത്തിൻ്റെ 4-ാമത്തെ വ്യാഴാഴ്ചയ്ക്കായി നന്ദി. ഇന്നും ഞങ്ങൾക്കിതുപോലെ അവിടുത്തെ നാമത്തിൽ കൂടുവാനും പുതിയ കാര്യങ്ങൾ ഗ്രഹിപ്പാനും കേൾക്കുവാനും ഞങ്ങൾക്ക് വേണ്ടി ഒരുക്കിയിരിക്കുന്ന ഈ സെഷനായി നന്ദി. ഇത് ലീഡ് ചെയ്യുന്നതായിട്ടുള്ള പ്രൊഫസർ ഡോക്ടർ വീണ വേണുഗോപാലിനെ അവിടുത്തെ കാര്യങ്ങളിലേക്ക് പ്രത്യേകമായി ഞങ്ങൾ സമർപ്പിക്കുന്നു. താൻ സംസാരിക്കുന്നത്, താൻ ഞങ്ങളോട് ഷെയർ ചെയ്യുന്നതൊക്കെ ഞങ്ങളുടെ പ്രൊഫഷണൽ ലൈഫിന് വലിയൊരു അനുഗ്രഹമായി തീരുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. വന്നു ചേർന്ന ഓരോരുത്തരെയും ഇനി വരാൻ ആഗ്രഹിക്കുന്നവരെയും അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥനകണ്ഠനായി നന്ദി. ഞങ്ങളുടെ കർത്താവും ഞങ്ങളുടെ രക്ഷിതാവുമായ യേശു ക്രിസ്തുവിൻ്റെ വലിയൊരു നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Good morning, everyone. It is a great privilege for me to introduce the speaker for today's quest, Professor Dr. Veena Venugopalan. So Dr. Veena earned her Doctor of Pharmacy degree from the University of Kentucky, College of Pharmacy in 2006, and she completed both a pharmacy practice residency and an infectious diseases specialty residency at the University of Kentucky Medical Center. In 2016, Dr. Venugopalan joined the faculty of University of Florida. She currently serves as a clinical professor at the University of Florida College of Pharmacy and is an infectious diseases clinical specialist at the University of Florida Health Shands Hospital. A board-certified infectious disease pharmacist, Dr. Veena has dedicated much of her career in establishing and strengthening antimicrobial stewardship programs in both large academic medical centers and community teaching hospitals. Her innovative contributions to antimicrobial stewardship have earned her recognition at both local and state levels. Her research and clinical interests include antimicrobial resistance, beta-lactam TDM, antimicrobial stewardship, and global health. Beyond her clinical and research accomplishments, Dr. Veena is a passionate educator, mentor, and advisor to pharmacy students and residents. She finds her greatest professional fulfillment in seeing her trainees grow, succeed, and achieve their highest potential. So I had the opportunity to meet Veena personally during one of the conferences in Amrita. That's how we started our collaboration together. And she looks very humble, but she's a big shot when it comes to the beta-lactam TDM. She has a lot of papers that are being cited, quoted by a lot of articles. You can see her. So she's an international figure in the field of stewardship and in antimicrobial TDM, especially with beta-lactam cefepime. So it is absolutely a great privilege for me to welcome her and that she's here. And the other exciting news, the most exciting news for us, is that through her we might have memorandum of understanding with the University of Florida, whereby their residents can come and train with us for maybe up to 1 month for their actual residency program in the America. So definitely this is something that we very much are looking forward to, and as a good friend, I'm very happy, and thank you so much, Veena, for coming all the way, and over to you for taking up this session on leveling up patient care, the value of interprofessional TDM. Thank you.
Hope everyone can hear me. Wonderful. Good morning, everyone. It's a pleasure to be here, and thank you for that introduction, Grace. And also a huge thank you to Dr. Grace for inviting me here to present today in front of all of you. And the main focus of our discussion today is going to be the value of, is that good? Okay, the value of interprofessional therapeutic drug monitoring. So I'm going to talk to you about how therapeutic drug monitoring is really a team effort, right? We'll talk about that. Okay, so a couple of objectives today. So this is our game plan for the day. We're going to discuss why antimicrobial pharmacokinetics is unpredictable in critically ill patients. And just by a show of hands, how many here are students or trainees? If I can see a show of hands. Okay, and physicians, pharmacists in the group. Yes, so medical providers. Okay, very good. So we have a mixed group here. So most of you have at least encountered critically ill patients. We'll talk about how antimicrobial PK is unpredictable in this host, and then we'll describe why therapeutic drug monitoring really belongs to the entire care team, right? This is not exclusively one individual's responsibility. It belongs to all of us. And then I'm going to share with you two frameworks, two redesigns of workflows that we've done at the University of Florida, which have integrated TDM into various formats, and hopefully that'll give you a better idea of how we have really taken this team-based approach to therapeutic drug monitoring. So first, where does this all happen? So this is the University of Florida Health Hospital. This is our cancer center. So we are a 1,100 bed tertiary academic hospital. We have over 200 ICU beds. And a number of different specialties that we offer at the University of Florida. We have a cancer center, a neuromedicine specialty hospital, and we are also the state's largest transplant center. So we have a pretty high patient acuity at University of Florida. And I'm a clinical pharmacist by training, and so just a little bit about our pharmacy services. We have a decentralized model. So we have specialists that are located at various places in the hospital. So we have over 80 pharmacists and 11 ICU specialists in the various care areas. And in terms of infectious diseases, we're about 3 ID pharmacists. And then where does our TDM work happen? I am extremely fortunate that we have a highly sophisticated lab on site. So this is besides our core lab services. The infectious diseases pharmacokinetics lab is on site at the College of Pharmacy, and it's run by Doctors Charles Pelequin, who is in his retirement phase, and so he's phasing out, and Dr. Nicole Maranchik is taking over the lab. They have 3 full-time clinical lab techs, as well as 1 part-time tech who does mostly research work. They have 5 LCMS instruments, and then they have we have access to a number of different assays for a number of different anti-infectives. All right, so I'm going to start this talk maybe at a point that's a little bit basic for our providers here, but I figure since we have a lot of trainees here, I'm going to start by demystifying TDM, because I think sometimes we use some of this terminology and it may not seem as intuitive to some of us. So what is therapeutic drug monitoring? So therapeutic drug monitoring refers to the individualization of drug dosage by maintaining plasma concentrations within a target therapeutic range or window. So I'm going to use a very simple analogy to illustrate this point. So let's take a bathtub, right? And assume your patient is like a bathtub. So the flow of water is your drug dose. The level of water in the bathtub is the drug concentration, and the drain is the renal function, right? So typically what do? We turn the faucet on, we turn the pipe on, right? And then we walk away, right? And we assume that that flow rate of water is going to be equal to the rate at which the water comes out of the drain, and the patient is going to be maintained, right? Now, the goal is to keep the water level between a range. You don't want the water level to go too low. You don't want the water level to go too high. So that range is referred to as the therapeutic window, right? Now, the complication is, as there always is with our patients, the drain size changes in our patients. It doesn't remain constant. So that creates a complication, because if you turn the faucet on and you walk away, and the drain size changes, you can assume what's going to happen then, right? The level that we expect the water to be at is not what's going to ultimately happen. And let's see what those situations are. Okay, so what happens in 3 scenarios? And I'll present 3 scenarios here. So in scenario number 1, what if the drain size gets bigger? If the drain size gets bigger, more water is going to go out, and your drug level is going to fall too low, right? And you have subtherapeutic drug concentrations. In scenario 2, what happens when the drain size gets too small? If the drain size gets too small, then your water level builds up and your drug concentrations also increase, right? Perhaps even to the toxicity range. So the two dashed lines represent the therapeutic window. But perhaps the most complex situation is scenario 3. In some patients, the drain size keeps going bigger and smaller, right? It's unpredictable. And then in that situation, really maintaining those drug concentrations within that therapeutic window gets extremely difficult. So this is where therapeutic drug monitoring can really become helpful. So therapeutic drug monitoring is the equivalent of every now and then coming to check what the water level is in the bathtub, right? So every now and then you're going to walk into the room and see where the water level is, and accordingly adjust the tap setting, right? And adjusting the tap setting is the equivalent of adjusting our dose, right? So everybody hopefully has that analogy in their mind. So why does the drain size and the water level keep going up and down in some of our patients, right? So patients are not bathtubs, right? So let's try to now talk about what this means in a clinical setting. We know that when our patients come into the hospital, there are a number of different physiological changes that our patients have, right? So we do several medical interventions on them. We give our patients vasopressors, we give them fluids, right? All of these interventions lead to physiological changes. They may increase renal blood flow, they increase cardiac output. All of these things ultimately changes the patient's renal function. And in this case, giving pressors, vasopressors, and fluids may increase their renal reserve. And the term that we use for increased renal reserve is augmented renal clearance. So these physiological changes also produce pharmacokinetic changes, right? So the patient's volume of distribution may change. So physiological changes produce pharmacokinetic changes, all of which ultimately lead to decreased plasma concentrations of drug in these patients. Now, in addition to that, we know that these patients also have variable pharmacokinetics and pharmacodynamics. So that concentration or dose to effect relationship also changes. And there are a number of factors that contribute to that variability in dose to effect relationship. So some of those other external factors include the pathogen, some equipment that we may use, patients who are receiving renal replacement therapy, and then there are medication level factors as well, such as protein binding, that may contribute to this. But the main point, the big picture here is that the changes in the water level in the bathtub, right, are really produced by physiological changes that are brought about in our patients due to medical interventions that produces PK changes, which may affect our drug concentrations. Okay, so some of you may say, you know what, I've been dosing, let's say for example beta-lactams for the better half of my career. Really, I've had no issues, and everyone's familiar, right? We've been using penicillin since the 1950s. Like, we all feel this comfort level with using our beta-lactams, and we know how to dose them, and we feel comfortable. So what's the problem with just doing business as usual, right? What's the issue? So I'm going to present this in 3 arguments, right, as to why we cannot continue to conduct our dosing strategies in the same way as we have previously been doing. The first is serum creatinine is a very poor predictor of renal function, right? So we use serum creatinine as a measure of the drain size, right? So remember the bathtub? So serum creatinine is our surrogate for drain size. But we know that we need up to 50% loss of kidney function before that serum creatinine even goes up, right? So serum creatinine is really not a great reflection of kidney function. Also, we know that there are things that may overestimate and underestimate serum creatinine. For example, rhabdomyolysis may overestimate serum creatinine, whereas we know that fluids can actually dilute and underestimate serum creatinine. So argument number one as to why we can't conduct business as usual is that serum creatinine is a poor surrogate for renal function. And the second argument is we know that renal function, particularly in early admission in our patients, is highly dynamic. There was a study by Ryan Krass and colleagues that showed that about 60% of patients who are admitted have AKI on admission. And this AKI rapidly resolves in the first 48 hours of admission. And I'm sure many of you have recognized this. Patients come in, perhaps they haven't been eating and drinking at home for a couple of days. They come in a bit dehydrated, their serum creatinine is elevated, and then we start them on a dose of antibiotics, and within the first 48 hours that AKI has completely resolved, right? But they remained on the original dose. And so being mindful of that is really critical. And the third argument is we know, and this is a more recent study, that package insert dosing really does not provide adequate exposure. And this was a study across about 7 ICUs in Sweden, and they looked at antibiotic exposure using standard doses of beta-lactams. And they found that only 45% of patients achieved what I would consider the minimum PK/PD target in ICU patients, which is 100% free time above MIC. That means for the entire interval of for that beta-lactam dose, the drug concentrations remain, the free drug concentrations remain above the MIC. So only 45% met that target at day 1 of hospitalization, and that target actually did not go up at day 3. Right? So giving our standard doses do not really improve or provide adequate antibiotic exposure. So these 3 arguments hopefully give you a better sense of really why TDM can be a useful tool to help us in determining whether our patients have adequate antibiotic exposure, and particularly our sickest patients. So I say this, but so does several international guidelines as well. So this is some language that is removed or excerpted from the 2021 Surviving Sepsis Guidelines. So the Surviving Sepsis Guidelines is a consensus document that provides recommendations on management of critically ill patients. And the language in the most recent update states that optimizing dosing strategies of antimicrobials using PK/PD principles should be applied, and also you should apply this PK/PD approach with the support of clinical team members, and also utilize therapeutic drug monitoring. So the Surviving Sepsis Guidelines now has specific language that states that therapeutic drug monitoring should be a tool and resource that we used to help optimize antibiotic dosing in these patients, right? Okay. Now, I want to mention once again the use of the term clinical team members. So the Surviving Sepsis Guidelines don't call out any specific discipline, right? They assume that there are several specialists, providers that have expertise in this area that can provide specialized knowledge in this area and that can provide support for TDM. So for me, TDM is the ultimate relay race in a hospital, right? And all of you hopefully have seen a relay race. In a relay race, you have multiple individuals, right? And much like any competitive race, in a relay race, speed is key, right? You want to make sure that you are running the fastest with the baton, right? But you cannot fumble. You cannot miss the opportunity to pass the baton on to the next person in the relay race, because a fumbled baton is a lost race. Similarly, when you're doing therapeutic drug monitoring, there are multiple individuals that make the whole TDM process work, starting from the prescriber that orders the concentration, the nursing staff that takes the levels, the lab that processes it, the pharmacist and the physician that interprets the level, the prescriber that makes the dosing change, and then finally the nurse that makes the change with the dose. Each individual has a part to play, and we need to make sure that this is done quickly but without any fumbling of the baton, right? So TDM is the ultimate relay race, and we're going to talk about how each individual plays a unique role in this process. Oh, excuse me. Okay, so now I'm going to switch gears and give you 2 examples of how we have incorporated TDM into our workflow. And the first one is incorporation of beta-lactam TDM. Thank you so much. Thank you for that. So the first one is incorporation of beta-lactam TDM into severe sepsis or septic shock order set. Okay. So let's first talk about beta-lactam TDM. So everybody may or may not be familiar, but beta-lactam TDM has really become a more popular, I wouldn't say commonly used tool, because I think it's still a very niche area, but certainly here at Believers Hospital, you have the ability and the access to beta-lactam assays. But we've seen it becoming more commonplace use within, I would say, the last decade and a half. So I want to summarize the data with beta-lactam TDM. Okay, so what do we know about beta-lactam therapeutic drug monitoring, right? We know that when we use therapeutic drug monitoring for our common beta-lactams, we can increase the likelihood of PK/PD target attainment. So we can optimize antibiotic exposure. We know that when we use this tool, we increase microbiological cure, we increase clinical cure, and if TDM is done earlier, we have improved patient outcomes. So these are the things that collectively studies have shown to date. There are, however, some things that remain undefined, right? So what are the optimal PK/PD targets? Are some of those PK/PD targets unique to specific indications, right? So do we have indication-specific targets? What are optimal endpoints for trials? I'm not sure that we have completely I don't feel like I feel settled about what the optimal endpoints are for some of these trials. What are the thresholds for toxicity? We know that beta-lactams are not completely safe antibiotics. We know cefepime, we see neurotoxicity with some of these agents, we see bone marrow-related side effects, right? So beta-lactams have long been considered antibiotics that have been safe, and they are largely safe. They have this wide therapeutic index. However, there are toxicities associated with it. While we have some good prospective studies that have been conducted within the last 10 years, none of the studies have been able to show mortality benefit yet. And also, it's still a little bit elusive as to which patients will benefit most from beta-lactam TDM, right? So these are the things that we know, and these are the things that have yet to be identified or better defined with beta-lactam TDM. So I want to present 2 studies here, and the first one is really addressing this issue with mortality. So a major criticism with previously done beta-lactam TDM studies have been we cannot find a mortality benefit because we've been unable to perform the TDM as close to time 0 as possible, right? So everybody has heard of the golden hour with sepsis. Well, because of our inability, and this is probably because most of the TDM studies have been done in a research environment. So as with most research studies, patients have to be consented, and that brings about a certain degree of delay in checking levels, right? So that's been a criticism of these studies, is that we haven't been able to check these levels early enough, and that's perhaps has contributed to our lack of ability to show mortality benefits. So Hansel and colleagues did a prospective cohort feasibility study. So what they did was they looked at adult patients who were started on piperacillin tazobactam meropenem, who had lower respiratory tract infections, and they looked to see if they could check TDM, deliver TDM results within the first 2 dosing intervals. So this was a feasibility study to see if TDM could be done early and how early it could be done. So they enrolled 30 patients from 2 ICUs. 63% of their patients were mechanically ventilated and 30% were on vasopressor support. So these were pretty sick patients. And what they found was in 67% of these patients, they were able to check a level within the first 2 dosing intervals. The median time from blood sample to result was 10.9 hours, and the median time from antibiotic start to result was 25 hours. And so while it was a positive outcome that they found that they were able to check these levels early, they found that the biggest delays in checking level occurred in the pre-analytical phase. So this is before the samples even got to the lab. So just think of that relay race, right? So before the sample gets to the lab, we know that the order has to be placed, the nurse has to go and draw the sample, and so when you're thinking about creating a workflow, this gives you some idea of places where we can perhaps create more standardized processes to try to expedite this. But that's what they found was while they were able to check levels faster, that pre-analytical phase seemed to be the time period where most of the delays occurred. So I ask you, we can get TDM earlier and earlier to time 0 or within that first hour of sepsis, but is the juice worth the squeeze? Like, does this really help patients the earlier and earlier we check levels and optimize antibiotics and optimize antibiotic dosing? So this was a very recent study. It was published within the last week or so, these investigators looked at the timeliness of antibiotics in patients who were immunocompromised and non-immunocompromised, and this was a retrospective cohort study, and the primary outcome was in-hospital mortality. And their exposure of interest was time from ED arrival to first intravenous antibiotic. So they looked at over 39,000 hospitalizations across 9 US hospitals. As I mentioned, their comparative arms were non-immunocompromised and immunocompromised patients, and their results were quite interesting. They found that when antibiotics were given within 1 to 3 hours compared with 0 to 1 hours, they found increased mortality in non-immunocompromised patients, but not in immunocompromised patients, right? So this is kind of counterintuitive, right? We assume that immunocompromised patients probably need antibiotics quicker, but they found that in the non-immunocompromised patients, they had increased mortality when there was delays. And this increased risk was limited to septic shock. There was no association seen in sepsis without shock. So the take-home message from this publication, at least from my perspective, is not that we should delay antibiotics in immunocompromised hosts, not at all. I think what the data is telling us is that we should use antibiotic urgency or determine antibiotic urgency by clinical severity rather than immune status. So historically, we've considered immunocompromised patients as being sicker, but this data suggests that our non-immunocompromised hosts are also susceptible to worse outcomes, and perhaps we should use clinical severity as our guide on antibiotic urgency. Okay, so this brings me to the crux of our workflow process. So we started our beta-lactam TDM program at the University of Florida in 2016. And in around 2023, we felt like we were ready. At that point, our providers had gained a lot of comfort level and confidence with using beta-lactam TDM routinely in clinical practice, but we had not integrated it into any standardized workflow. So at that point, we decided, let's give this a try, and we're going to start with severe sepsis and septic shock. As I previously discussed, these are the sickest patients in our hospital. So if we were going to utilize a resource like beta-lactam TDM, it should be in those patients that have, one, most variable PK, and two, who are the most critically ill. So we convened a team, a multidisciplinary team that comprised of patients from quality, pharmacy, as well as our physician peers, and we decided to map out this process. If we were going to integrate beta-lactam TDM into severe sepsis and septic shock, what would this process look like? And we conducted something called a failure mode and effect analysis. An FMEA is a tool that was developed by the Institute for Healthcare Improvement, and it really helps you identify failure modes within a process. So this is an example, this worksheet of how we did this, and this took several weeks to complete. And basically, this requires you to map out every single step of the workflow. And it could be something as easy as the nursing staff places a label on the tube. And once each step in the process is identified, we score and prioritize them. And highest score being with a concentration was mistimed, and this resulted in an incorrect concentration, which led to incorrect interpretation and the patient being wrongly dosed. That would be the highest priority. Right? So once you have done this, you then redesign your workflow to try to mitigate some of those failures. And then the idea is that you end up with a workflow that you've already pre-assessed some of these gaps that can potentially lead to poor or worse outcomes, right? So an FMEA, if you think about it, is the reverse of a root cause analysis, right? In a root cause analysis, your negative outcome has already occurred and you're trying to work backwards to determine what happened. With an FMEA, you're proactively looking at the workflow to see where the gaps are to try to address them before they occur. So once that happened, we came up and we have a pretty, I would say, complex pharmacist workflow. So we had to figure out a workflow that would accommodate beta-lactam TDM during the hours that our clinical specialists were in the unit, and then an alternative workflow for when our clinical pharmacists were out of the unit. So this is just an example. I'm not going to go into too much detail, but just to show you that we created a process, and what that eventually led to was, and this is just the definitions for our for severe sepsis and septic shock in our EMR. What that led to us doing was we embedded beta-lactam TDM, and the star represents where it is. So this is our order panel for severe sepsis and septic shock. So the two antibiotics that we use there in this scenario are either cefepime or aztreonam. So rather than placing the order for a level, because remember the level will be very time specific, we placed an order. It's called a placeholder order, which is just a reminder for the pharmacist to order the level. And that was how we determined was the best workflow for our pharmacists, because they were the primary drivers for the ordering of the level. So that aspect of this workflow. So this order set included a placeholder, which was a reminder for the pharmacist to see when the cefepime dose was given, and then order the concentration accordingly. So this is just a quick review. We did an analysis of our process a couple of months after starting. So we looked at 215 patients between March and November of 2024. 211 received cefepime, 4 received aztreonam, and we initially implemented this in 5 surgical units as a pilot. What we found was that, and we defined compliance with this process as antibiotic concentrations ordered within 72 hours of that placeholder order. We found that 62% of our orders of our patients were compliant with this new workflow, right? So 62% were compliant. So initially that made me a little bit troubled. I said, those numbers are great. But then we did a deeper dive into why the deviations occurred. And the most common reason for an antibiotic deviation was because the antibiotic was stopped. So that's good news. So somebody was actually being good antibiotic stewards and stopping it. And the remaining deviations were due to early discharges, so discharges within that 72 hours. So overall, if you put that into context, the 62% actually looks good because the vast majority of our patients were being appropriately followed in this new workflow. Then we also looked to see how many of these patients actually had a dose adjustment. So remember, these are severe sepsis and septic shock patients, right? So this is a bar graph. So of our patients, about a quarter, 1 in every 4 patients with severe sepsis or septic shock required some kind of dose adjustment of the beta-lactam. And I've shown for you in the orange bars those patients who required a dose adjustment to increase antibiotic exposure. So that meant they were switched to a continuous infusion or an extended infusion, or they had an increase in the dosing frequency. And the gray bars show you those patients who had needed a dose reduction because they had too much antibiotic exposure. So they either had a dosing frequency decrease or a decrease in the total daily dose. So overall, and this was surprising to me, about 50% of the patients who needed a dose adjustment, about 50% needed an antibiotic, some kind of dosing adjustment that was needed to increase antibiotic exposure, and in 50% they needed a change to decrease antibiotic exposure. My assumption was that these was primarily surgical units, and being surgical units, I assumed that these patients might have augmented renal clearance and that we would be doing a whole lot more dose increases than decreases. But I didn't factor that we have a lot of vascular patients in this mix, and a lot of those vascular patients, particularly post-surgically, have AKI, and that probably contributed to the 50% in which we needed to have dose reductions. And we also had, of the 103 patients that we didn't make a dose adjustments, the reason was some of them were stopped. So in 24 cases, and in 5 cases, the antibiotic was switched to alternative agents. Okay, and then we looked at the third metric, was the average time from when the placeholder was placed to when we checked concentrations, and it was about 26 hours. So not bad. I would like to bring that down, but this is a real world workflow because our lab doesn't do TDM 7 days a week. We only do it 5 days a week, and the assays are only done during business hours. So the 26 hours really represents realistically what we can do as a working hospital with a lab and with the limitations that we have on the fastest or most speedy time to checking levels. Okay, so that was the first example. I want to switch gears and show you a second example of how we have integrated TDM, integrated other stewardship-related interventions into TDM and our PK consoles. So this was a project that I did with a resident, and we started in 2018, so it's been several years ago, but I want to share with you the results and also what we've done since then. So it was a program or a pilot project that we called SCAN, Stop and Reconsider Advancing Consult. So the crux of this, or the main driving force behind this project, was to try to incorporate an antibiotic timeout in our PK consult process. So most of you must be familiar with antibiotic timeout. So an antibiotic timeout is a structured pause in antibiotic therapy, and frequently this is done at hour 48 to 72, and the purpose of an antibiotic timeout is to really reassess whether continuation is necessary, continuation or modification, right? So I've compiled a couple of studies here, and some key things that we know about antibiotic timeouts are they work when they're embedded in the patient's workflow, right? If you try to create a timeout process that is outside of the typical patient care workflow, it doesn't work. we know that generally there's no harm to our patients when we perform antibiotic timeouts, and most of the studies show that as well. It's perfectly safe to do this, and there are also a number of ways to conduct timeouts. You don't have to do it universally for all antibiotics. You can focus or dedicate antibiotic timeouts to broad spectrum high risk antibiotics. So these studies have shown that when you conduct antibiotic timeouts, you can drop inappropriate antibiotic use, you can reduce costs, you can improve patient survival, and you can also reduce antibiotic days of therapy. So why did we even venture into doing this project? Because we were approached by our hospital administration in 2018, and they said, our pharmacists are spending a lot of time doing vancomycin therapeutic drug monitoring. Can you really tell us if we're gaining any returns on this investment with our pharmacist time? So we started by even just looking at the background, right? Does our vancomycin consumption really add up with our MRSA rates? And it didn't. It didn't make sense that we were using more and more vancomycin year after year, but our MRSA rates were coming down. And this is a phenomenon that we're seeing across the US. MRSA rates are declining. So it didn't quite match up. Then we looked at our PK consult process. So the vancomycin PK consult process is really driven by pharmacists at the University of Florida. So the provider will place a PK consult, that's step one. The pharmacist will process the consult and then order the dose of vancomycin as well as levels. Then the pharmacist will continue to follow the patient every day until the physician decides to stop the vancomycin, and then the consult is done. So what we recognized was that the pharmacist, the PK consult process was performing like a dosing service than a true consult service, right? Because at no point during the PK consult was there any evaluation of appropriateness of therapy. The pharmacist was simply dosing. So we decided to create an alternative process. And what we said was at 72 hours, we're going to embed a timeout. So step one is the PK consult is placed by the physician. The pharmacist then processes the consult, orders the levels, and at hour 72, they're going to stop and assess whether vancomycin needs to be continued. So this is our scan criteria. So we said that vancomycin can only be continued if one of these 5 criteria are met. Positive cultures for MRSA, history of MRSA within the past year, cultures that were still pending, right? Whether if they had a severe beta-lactam allergy where there was no alternative, or if they have purulent cellulitis. So if they met a criteria, they could continue the consult. If they did not meet the criteria, we asked that they involve the infectious diseases consultants. And in some of these cases, these patients did have culture-negative infections, culture-negative endocarditis or osteomyelitis, where more specialized expertise from our infectious diseases colleagues was needed. What we found was we did an evaluation of the process, and this was an evaluation of 269 patients. We found 157 of those patients were reviewed by the pharmacist at hour 72. So it means scan was performed at the 72-hour mark. And what we found was when scan was performed, when the antibiotic timeout was performed at 72 hours, we were able to stop 57% of our vancomycin, right? So simply having a conversation to say, do we still have an indication, is vancomycin still appropriate at hour 72, really did start that conversation with the provider as to whether this was needed or not. In fact, some feedback that we got from our providers was that when they got a call from the pharmacist for the antibiotic timeout, they often considered the necessity of other antibiotics. Oh, I'm stopping the vancomycin. Maybe I can also stop the other antibiotics. So we had de-escalation globally, not just with the vancomycin when this was done. So some of the most common reasons for continuation of vancomycin was cultures were still pending, so really there wasn't a comfort level to stop the antibiotic because we didn't know what the offending organism was. The patients previously had MRSA, so those were the most common reasons for continuing vancomycin. What we were able to show from scan was that stopping the vancomycin, we were able to reduce the vancomycin days of therapy by about 1 day, and this was a statistically significant difference in the hospital length of stay. Okay, now one thing I'd like to really emphasize is when you bring about a new workflow or a new process, it's not a one and done, right? And this was a great example of how you need continual processes to audit and improve these systems and processes. So we set up SCAN in 2018, but we really didn't go back to reevaluate whether SCAN was still working, except in 2025. So this was another resident project where we reevaluated SCAN, and what we found was, and we'll just skip to the bottom here, SCAN was basically not being performed, because what we found was of 138 patients that we evaluated, 67 patients did not meet SCAN criteria. That means they did not meet one of those 5 points for continuation of vancomycin. And of those 67, in about half of those cases, vancomycin was not stopped, which means vancomycin was continued without a clear indication. So from 2018 to 2025, we really hadn't done any continuing education with our pharmacists and physicians to remind them of the importance of antibiotic timeout with vancomycin. We let this slide, and this came back to bite us in the backside, because now we feel like we have to reintroduce this new process and refamiliarize our providers with this process. And some additional things that we found was SCAN was not being done, which led to more days of vancomycin. We found that when those patients were continued on vancomycin, 58% had 1 to 2 excess days of vancomycin, and 42% had 3 or more days of excess vancomycin. But perhaps most concerning is that we saw that of the cohort of patients who were continued on vancomycin, we saw that 8 patients, 22%, actually developed AKI, right? So we know that continuing vancomycin is not benign, so continuation of it does have consequences. So in summary, what makes TDM a team sport? So we know that whatever new process that you develop or create that integrates TDM, you want to make sure that it is 100% integrated into typical or normal patient care workflow. In order for it to work, it has to feel seamless with normal patient care. And we always have to define the why. And defining the why may require you to collect some baseline data from your institution so that your providers understand why these new processes are being created and the value of them. Convening a multidisciplinary team with any or all of the key stakeholders is always important, because there's always different perspectives that are brought on by people who are more familiar with specific patient groups, and also the value that is brought in. Remember the relay race. Every person in the relay race has a specific task to play. Therefore, incorporating everybody is crucial in ultimately having a workable process. Also, a lot of these workflow-related processes that we create are really opportunities for creating conversations. We want providers to talk to each other, right? Because speaking with each other and creating these opportunities for conversation ultimately, at least in my experience, always improves patient care, improves patient safety. And let's not forget, when we create something new, there always has to be a continuous audit and feedback process in place, because things happen over time, right? We all get complacent, behaviors tend to slide backwards, and so having, whether it's education, whether it's audit and providing data on the outcomes of some of these processes, but whatever the approach you take is, this continuous audit and feedback is extremely important. Okay. So I think I'm right on time. It's 9 o'clock, and I'd love to once again thank all of you for giving me the opportunity to present here today, and I'd like to open it up for any questions that you may have. Thank you so much.
Any questions?
Veena, thank you for that fascinating 1 hour. We were just sitting right there listening to all that you said. I didn't want to stand up because I think all of you have a lot of questions to ask. Just keep remembering that relay race, and each one of you fit in somewhere. And when do we start asking these questions which Veena posed to us? For example, I'm sure the clinicians here must be wondering, why am I giving all those antibiotics? When do I stop? Why aren't I stopping it earlier? Surgeons, Dr. Sukriya, Stephen is here, I saw. Lots for us to learn from you, and lots that we can do, because we've got an international star amidst us in Sumit Matthew, and I'm sure we can do much better. And thank you for introducing this thought to us so that we can start making this part of our lives on a daily basis. Thank you.
Hi, Dr. Veena, I'm Sumit. I usually see people who are either interested in TDM or antimicrobial stewardship. But you are a person who is doing both together, and you perform TDM and also stop antibiotic use when it's right time to stop it. So we have introduced TDM in our institution maybe around 1 year back, 1 or 1.5 years back, and I'm truly happy to see that a lot of our clinicians are requesting for TDM services, and thankfully there are a lot of people questioning the role of TDM, and I'm actually happy to address that part, because recently we are seeing questions like why do you need so much of dose hike and patient is relatively healthy. So yes, I would like to hear those questions. When questions come, there can be interaction and there can be solutions. So what is your opinion on what are the usual barriers that you have identified in setting up TDM services in your institution?
Thank you, Dr. Sumit. Very nice to meet you. I've been wanting to meet you. I've heard a lot from Grace, and I've followed your work over the years, and so it's a pleasure to meet you. But so 2016 for us, I think people assume adoption of beta-lactam TDM specifically, I'll speak to, at University of Florida was actually a slow process. It did not happen overnight. It took a lot of convincing, and it partly because I feel like most providers have an established track record with beta-lactams, and they have a certain comfort level, and it was difficult to step outside of it. What our approach was to identify early adopters. So we are a center for cystic fibrosis. So we identified very early that those providers could be our biggest allies, because they've reached the end of the road with antibiotics for their patients. They have a metabolic patient population. Cystic fibrosis patients burn through antibiotics, and they have a massive level of antibiotic resistance as well. So they were very keen to partner with us, because they knew there was very little for them to offer their patients beyond switching them to very, very broad spectrum antibiotics. So once we had their support, we were able to start using it more so in their patient population and generate data to show that we could really change outcomes in this patient population. And I think that kind of bled into other patient care groups. That was one. Second was burn. Our burn ICU physicians were also early adopters for similar reasons. They had hypermetabolic patients, third spacing all this fluid, they were losing drug everywhere, and our burn patients tend to get more of these multi-drug resistant pathogens as well. But we were able to show the benefits of using TDM in that patient population as well. So the conversation really, it has to be a two-way street. I think that our initial approach, I can say, I had a partner who helped me build the program, and his approach was, you got to do it on everybody. And I think that perhaps rubbed people off the wrong way, because truth be told, I will tell you, I don't think every patient needs beta-lactam TDM. I think there are some patients that would benefit most from it. And I think we're learning more and more as more studies, developed studies come out. We're learning more about what that ideal patient looks like, right? But I often tell providers, if you're thinking about checking level, it's probably because you think that that patient needs it, right? And so that's been my approach. Is I'm less aggressive about telling providers that every patient needs it. However, we have partnered with some of those high-risk groups. Our ICU providers have been very good partners for us as well. And we've also been able to show its utility in niche areas. Toxicity is one. So we get a lot of consults for neurotoxicity because we use a lot of cefepime as our workhorse anti-pseudomonal agent, and we hear a lot about patients being switched to carbapenems because of neurotoxicity. But we've been able to show in a lot of cases that cefepime is unlikely contributing to neurotoxicity. So by picking those patient populations, we've been able to successfully gain the confidence of providers slowly over the years. And now there's no questions asked. But I can tell you it didn't happen overnight. It did take some time. Yes.
I have one more question.
Sure.
You have started your work from maybe 2012 or something?
Yes, 2016.
2016. So, are you seeing a worsening of antibiotic resistance over a period of time with TDM use, or how is your antibiotic resistance pattern because you are implementing TDM in your hospital?
Yeah. That's a great question. We are seeing globally more resistance. I'm not sure I can attribute it to lack thereof, or of not using TDM necessarily. I think generally our resistance patterns are worsening. Some of that is because of medical tourism. Some of that is because of selective use of some anti-pseudomonal agents. I'm not sure, because even when we look at our institution, we're still only doing beta-lactam TDM in a small sliver of our patients. We're still, I would like for us to do it in more patients than we are, but we aren't doing it in the vast majority of patients, I would say. But we are seeing more resistance, but probably not due to lack of TDM and dose optimization. But I will say, I think the first time that you see a 70 or 80-year-old patient clear drug than like a 20-year-old, and when the first time you see a 20-year-old clear drug like a 70-year-old, that sells TDM like nothing else. So I would encourage Grace as well as you to share those stories, because I can't explain it sometimes when we check a level in a 80-year-old, and I can't keep cefepime or piperacillin tazobactam in their system long enough to meet even 100% time above MIC, because they're clearing drug so fast, and we don't expect it to. Similarly, we have some young patients that clear drug like they're decades older. So, but sharing those stories, I think, it can be very powerful as a means to sell this.
That was an excellent presentation. I am an ID physician here, so I have experience for last 1 year. So our believers all departments are doing great. Almost 70% of the people are doing TDM within 1 year, especially from nephrology department. We are using linezolid only 300 mg OD, and we are having a least side effect of linezolid toxicity. And especially in ICU people, especially surgical ICU teams, they started to do TDM. People are improving very fast because they will be having 2 liter output here and 1 liter output from urine, almost 3. So surgical patient, it is very useful. In my view, TDM should be used in all surgical ICU patient. But another one thing we have found regarding cefepime, almost half of the people with cefepime had toxicity level, but no one had a neurotoxicity in Indian population. So
Sorry, repeat that. No neurotoxicity?
They don't have neurotoxicity.
Oh.
So that is very different. Whenever I am reading in outside paper, this level causes, but our Indian population, it is very less likely. I don't know what is the difference between the blood-brain barrier or the genetic factors. And one more thing regarding TDM in ATT in hematology patient, even with low dose of pyrazinamide, they are developing DILI. Patient with pyrazinamide 325 mg developed DILI. So these are the very, TDM is giving me more and more and research oriented thing, which I can't predict it. Now certain patient can tolerate sulbactam more than, some patient of sulbactam has received more than 80 or 90. They are doing well, there was no side effect, there was no seizures. So TDM is very enlightening, and it always keep learning, and it will never stop.
Thank you for sharing that. And absolutely, I think TDM is really an eye-opener. I think it really sheds light on how unpredictable exposures can be, right? And yeah, absolutely. And I would encourage you to share your data, because the more we hear of these stories, I think that's what really pushes the field forward, is the clinical experience, and also the integration of some of these testing assays into clinical use. Yeah, the implementation side of things, I guess. But thank you for your experience. Yes.
Now we are incorporating our TDM in code sepsis. We will also start to do TDM within 48 hours of patient who comes in emergency. Next month we will start at a mandatory. Now it is not a mandatory. Now we only introduced code sepsis. Soon we will do that in our next month.
And I've always found this. I mean, we spend, our pharmacists we spend a lot of time dose adjusting for renal function. I feel that the dose adjustment within the first 48 hours is probably unlikely necessary, because their patients' renal recovery is so rapid. Those patients were coming in with AKI. So I think aggressively dosing down too early in their admission likely leads to underexposure. That is my hypothesis. I don't know. I don't have data to support that, but
actually,
yes.
Changes from patient to patient. A patient who comes with an LRTI with heart failure, he will be on diuretics, but his creatinine level will be 4. But output will be 3 liter. This patient needs. So that take a decision on TDM will be depend upon the ID physician who is seeing at the emergency.
Absolutely.
Thank you.
Thank you for your question.
Thank you, Veena. We also aggressively dose our patients with AKI in the ICU, because we also feel they get underdosed. So thank you so much for a very enriching presentation, and also putting TDM as to a concept that is so much easy for others to kind of digest and adapt, and the studies you so passionately presented. Thank you so much. I would like to call Dr. George Andy sir, our director, to give Veena a token of appreciation from our end. Thank you, everyone.